The goal of this presentation is to show you some clinical examples of several pathologies of the quadriceps tendon and the patella in musculoskeletal ultrasound. All pathologies presented are exemplary and serve as practice for the pathology checklist. This is a longitudinal depiction of the suprapatellar region, showing the quadriceps tendon, the patella, and the suprapatellar recess. This is a transverse image of that same quadriceps tendon. The shape of the quadriceps tendon has changed due to increased thickening of the tendon. The suprapatellar recess shape has changed mildly as well. The echogenicity of the quadriceps tendon has changed in various ways. The upper layer of the tendon, containing the rectus femoris fibres, are hypoechoic because of a moderate tendinopathy. These tendon fibres are in disrepair. The fibres of the vastus lateralis and vastus medialis show for the biggest part anechoic. The fibres of the vastus intermedius show the normal echogenicity. They are a little bit more hyperechoic, but this is an artifact of enhanced imaging due to the swelling in the middle part of the tendon. Near the patella, a more hyperechoic zone can be seen. This is due to a pre-insertional calcification. The echogenicity of the suprapatellar recess has turned anechoic due to synovial fluid originating from the knee joint. The continuity of the upper and lower fibres have not changed. The fibres seem to be intact. The fibres of the vastus lateralis and vastus medialis, the middle layer, seem to have been disrupted. Transverse ultrasound of the quadriceps tendon shows that this disruption is not only in the middle of the tendon longitudinally, but also transversely. The green arrows point out that the lateral and medial thirds of the tendon remain unaffected. The red arrow indicates the site of pathology. Power Doppler of the longitudinal quadriceps tendon shows a moderate intratendinous hyperemia. Based on this static image, it cannot be confirmed whether there is a functional problem. We can assume, based on previous findings, that this patient shows a grade 2 partial tear with moderate hyperemia. Grade 2 means it's moderate and involving 25 to 50% of the height of the tendon. The tendon also shows a moderate tendinopathy and a pre-insertional calcification. The suprapatellar recess has swollen, maybe due to additional intra-articular pathology. This conclusion should be confirmed by making a left-right comparison and by scanning both longitudinally and transversely. Measurements of the tendon thickness, tendon cross-sectional area, tear size, and suprapatellar recess dimensions have to be made to accurately document the pathology for diagnostic and/or evaluative purposes. This is a longitudinal scan of the quadriceps tendon insertion to the patella. The quadriceps tendon shows a change in shape due to a concavity of the quadriceps epimysium. The suprapatellar region shows a change in echogenicity. Please note the anechoic parts, which seem to be fluid arising from the suprapatellar recess. The yellow box indicates a hyperechoic structure, which can also be confirmed on X-ray. It seems to be an avulsion of a calcification from the tendinous insertion. Please note the distal ends of these quadriceps layers, which remain attached to the patella. Based on this static image, it cannot be confirmed whether there is a functional problem. We can assume, based on previous findings, that this patient shows a complete tear with retraction of the quadriceps tendon. Fluids of the suprapatellar recess have migrated to superficial through the complete tear. This conclusion should be confirmed by scanning both longitudinally and transversely. Measurements of the tear size and suprapatellar recess dimensions have to be made to accurately document the pathology for diagnostic and/or evaluative purposes. This is a longitudinal scan of the patellar region. Please note the distance from the skin to the top of the image. This indicates that a bigger amount of gel has been placed on the patient's skin and that the transducer has been placed on that very lightly. All of this has been done to reduce the pressure on the pre-patellar region. Because of this, the pre-patellar bursa can be scanned. Too much transducer pressure would have squeezed the bursa, with a false negative as a result. This image shows that the pre-patellar bursa has changed in shape and increased in thickness. Colour Doppler imaging reveals an increased vasculature within the thickened bursal walls, reflecting inflammatory hyperemia. Based on this static image, it cannot be confirmed whether there is a functional problem. We can assume, based on previous findings, that this patient shows an acute pre-patellar bursitis. This conclusion should be confirmed by scanning both longitudinally and transversely. Measurements of the bursa dimensions have to be made to accurately document the pathology for diagnostic and/or evaluative purposes. The left image is an X-ray of the patella. The right image shows a longitudinal ultrasound scan of the patella. We know that ultrasound is not the golden standard for assessment of bony tissue. Still, in some cases, it's evident that the bone is fractured, like in this case, where a clear disruption of bony tissue can be seen. Based on this static image, it cannot be confirmed whether there is a functional problem. We can assume, based on previous findings, that this patient shows a patellar fracture. An X-ray has to be made to assess the full scope of the fracture. This is an ultrasound scan of the patellar tendon in transverse plane and in longitudinal plane. This transverse view of the tendon shows that the medial and lateral portions retain a normal fibrillar appearance, in contrast to the middle of the patellar tendon. This middle part of the tendon shows a change in shape due to an increase in thickness. It's important to assess all fibres of an anatomical structure when scanning longitudinally and therefore focusing on only a part of the anatomical structure. The upper image in the middle of this slide shows the pathology site. When sweeping the transducer towards medial and lateral, the same ligament appears to be healthy. The echogenicity has changed. Parts of the patellar tendon have turned hypoechoic, but some parts have turned hyperechoic. Colour Doppler imaging shows local hyperemia around the deep tendon surface. Some parts of the tendon look really dark, and small partial tearing can't be ruled out. Based on this static image, it cannot be confirmed whether there is a functional problem. We can assume, based on previous findings, that this patient shows a jumper's knee with a severe degenerative tendinopathy, possibly combined with mild partial tearing. A small intratendinous calcification within the focal hypoechoic area and a mild hyperemia are present as well. This conclusion should be confirmed by making a left-right comparison. Measurements of the tendon thickness, tendon cross-sectional area, tear size and calcification size have to be made to accurately document the pathology for diagnostic and/or evaluative purposes. This clip shows the patellar ligament and the transducer that sweeps from medial to lateral and back. Please note the tendinopathy in the middle and the healthy fibres on the lateral and medial side of the tendon.